Good evening. This is Dr. John Bennett broadcasting from Miami. Tonight we have another in the series of Parkinsonism educational hangouts with Dr. Abdul Rana MD, neurologist and world-renowned Parkinsonism educator. Tonight Dr. Rana is going to be talking about freezing and Parkinsonism. Good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you tonight?
Very, very good. Okay, let's start off with the first question. How is freezing related to Parkinsonism?
Freezing of gait is quite known in the history of Parkinson's disease. If we go back and look at the history, about 300 BC, a Greek professor, Esdras of Cois, he described in his writings a walking difficulty, which he calls paradoxos, a type of paralysis in which a person walking along must suddenly stop and cannot go on, but after a while can walk again. So he is describing the fascination. He is describing the freezing of gait with the start hesitation. When a person starts to walk, then his feet are frozen, and he can start walk again. So if you look at another text by François Delacroix in 1763. He described his observations in two patients. These patients were elderly, and he wrote difficulties in the initiation of walking due to decreased muscular flexibility. So he was quite right. This was freezing of gait, and he described that they had trouble initiating their walking. The freezing of gait is an episodic inability which lasts for several seconds to generate an effective stepping in the absence of any other cause except Parkinsonism. It is a transient phenomenon which occurs all of a sudden and affects both legs, and patients feel as if their feet are glued to the ground, especially when they try to lift their foot to step forward, or they want to go through a narrow hallway or step into an elevator. This could happen at the start of walking, usually called start hesitation. This could also happen when they are trying to turn, and it can also happen when they are going through a narrow space, which is called tight quarter hesitation. And sometimes when they reach a destination, they could still freeze. Patients have trouble dealing with the barriers or time-restricted activities, such as going through a revolving door or going through heavy traffic areas or narrow hallways. And freezing is much less common when patients are trying to go upstairs as compared to walking on a smooth surface. Indeed, I had a patient, and the spouse was describing her freezing and was saying, "Doc, she just gets stuck when she is walking, in the house. And I don't see any problem when she goes upstairs. She walks like anything, So he was probably because they feel the cues from the edges of the stairs, so it is easy using those cues and going upstairs. So he was describing his observation, which was right. Freezing of gait has been more recognized since 1970s because it has a very complex reaction to levodopa as compared to other symptoms of Parkinson's, like bradykinesia and rigidity. They would respond to levodopa, but when it comes to freezing has very complex response to levodopa. So sometimes focused attention in the external cues can help patients to overcome freezing. And freezing of gait is usually seen in the late stages of Parkinsonism, also it's more common in atypical Parkinsonism as compared to idiopathic Parkinson disease. Mild freezing could occur in the beginning stages of Parkinson disease, and freezing is very much associated with the motor fluctuations, like the periods of on and off. It is much more common in off state when the effect of levodopa wears off, but it could happen in the on state as well. Dual tasking, like a cognitive load, if you ask patients to count backwards or give them any other mental activity, such as calculation. So these type of phenomena would aggravate freezing. Whereas if they have visual or auditory cues, they would help them to overcome the freezing of gait. The freezing of gait is much more common in atypical Parkinsonism, such as progressive supranuclear palsy or vascular Parkinsonism, and is less common in idiopathic Parkinson disease when you compare it to atypical Parkinsonism. Most of the patients, they have, because Parkinson disease is a asymmetrical, it has asymmetrical onset, especially in the beginning. One side of the body is affected more than the other side. So most patients have a favorite side of turning, and they usually prefer to turn towards the more affected side, so that their less affected side can rotate easily. When patients attempt to cross a busy street before a signal would change, or when they're stepping into a room, going through a doorway, so they get stuck there, and these kind of situations can precipitate their freezing. If you draw a line in front of them and tell them to step over the line, this can break their freezing. And once they break the freezing cycle, they can start walking again like they were walking before. So this phenomena of stepping over a line, this has translated into use of the inverted canes, that patient can use the cane upside down, and they can try to step over the handle of the cane, and it does help them to break the cycle of freezing. Also, sometimes the carpet patterns, if they have a pattern on the carpet with the lines or some kind of design, so that could act as a visual cue for these patients, and they can and it can help breaking the episode of freezing.
What factors make the freezing worse?
Freezing of gait is related to the severity of disease, the longer duration of levodopa treatment, as well as dyskinesias and the early morning dystonia. So more severe the disease is, or longer the duration of levodopa, or more severe are dyskinesias, so these patients would have more chances of having freezing, and their freezing would be more intense as compared to those patients who have less of these factors. Motor fluctuations of off and on seem to be a factor in aggravating the freezing, and if we see intense or severe freezing in the beginning of Parkinson's disease, that could suggest that patients may have atypical Parkinsonism, because the intense freezing usually does not happen in the early stages of Parkinson's disease. A mild freezing is possible, which may not be detected easily and go undetected. There are some other associations with freezing, such as dementia, pseudobulbar palsy, or urinary incontinence. In Parkinson's disease, there is a dependency of the patients upon the mechanisms of movements, the voluntary mechanisms of movements, and in this voluntary system, there is imbalance of the intrinsic and extrinsic input. So freezing is usually due to a deficit of these intrinsic factors. So freezing is also much more common in the environment which has complex visual stimuli, such as train stations or wide open spaces, empty car parks, or cricket fields or shopping centers, etc. And so one explanation could be that this is a disorder in the sensory motor processing of the basal ganglia, and it is associated with the disturbed caudate function. The caudate and putamen, because they receive the input from the cortex, caudate and putamen, which could be called striatum, they receive input from the cortex, so they are considered to be a sensory component of the basal ganglia, whereas the globus pallidus internus it is considered more important in the motor control. And when there is a problem with this sensory motor processing, so this could lead to freezing of gait. The freezing in atypical Parkinsonism is usually more severe as compared to typical Parkinsonism, idiopathic Parkinson disease. Also, in atypical Parkinsonism, the freezing of gait could be more resistant to the dopaminergic treatment as compared to the idiopathic Parkinson disease, in which freezing of gait may respond to some extent or to a good extent to dopaminergic medications. Now, the freezing of gait, as I said before, because it occurs in off periods, and therefore it's referred as off freezing, and sometimes it occurs in on periods, although it's much less common, and is referred to as on freezing. So it's very important for the treating physician to differentiate these two phenomena. When the patient reports the freezing of gait, they should differentiate whether the freezing is in the on periods or off periods, because the treatment strategies are much different for both types of freezing. And the sensory and motor cues, as I was saying, they're quite helpful to overcome freezing, at least for a short time.
How is freezing examined, Dr. Rana?
The freezing of gait is quite prominent or easily noticeable if the proper examination of the gait is done. In the overall, in a general neurological examination, the gait is very important, the assessing of gait. And what I learned when we were going through training, that gait gives you a lot of information. Just the examination of gait can give you half of the examination for a neurological exam. So it's very important to look at a patient walking through the different situation. Like, they should stand up from a deep seated chair and then start walking, and they should be made go through a doorway, and then a narrow hallway, and then turning and coming back and sitting into the chair. So if you look at the complete cycle, so you can notice the freezing of gait if a person is vigilant to the gait of the patient. However, when you are examining in the routine situations, or if you are assessing specifically for freezing, so it should be done in a standardized gait trajectory, in which all possible components should be seen, and patients should be seen walking through all the circumstances which can provoke freezing. Some people use the time up and go test, in which patients are observed while they are rising from a chair. They walk for 3 meters at least, and they're turning around and walking back, and they're sitting in the chair again. So this test is quite helpful to assess the freezing of gait, and you can have some idea. So sometime you can use Parkinson Activity Scale, which is another test. It also scores the quality of gait as well as timing of the gait. In this Parkinson Activity Scale, the time up and go test is included, but it's more specific for the freezing of gait, because patients have to turn in a very tight square. So in addition to timing, you look at the score of the severity of freezing of gait, as well as gait initiation and gait turning, using a 5-point scale. So this gives you a lot of information. And it may include cognitive dual tasking, such as counting backwards, or motor dual tasking, such as carrying a full glass of water when patient is undergoing this test. So patients with freezing of gait, they may receive a cognitive examination, especially testing for the frontal executive functioning, because the frontal executive functioning and attention, these are quite related to the gait impairment in Parkinson's disease, and they are associated with increased risk of falling.
Is there any role of physiotherapy or L-dopa or surgery to improve freezing and Parkinsonism?
Freezing of gait is quite a difficult symptom to treat completely. So you may improve it partially. So all possible resources you can apply to improve this should be used. Physiotherapy definitely has a role in the treatment of freezing of gait. The physiotherapist can spend a good amount of time with the patient, and they can assess the effect of cueing strategies. They can make the patient trained for that, and they can also look at the cognitive movement strategies, and they can give a very tailored advice, such as making a larger turn. When patient is going in a straight line and they have a turn, instead of making a narrow turn, they should make a wide turn. This would help them to avoid freezing and paying increase and more attention to their gait, and avoiding any dual tasking like carrying things in their hands, etc. Physiotherapists, in addition to this, and occupational therapists, they could make a home visit, and they can look at the atmosphere in the house, which can be changed to help the freezing of gait. And most of the time, because patients live in the house, so examination of the home is very important, so that things can be modified to help their balance and gait, as well as freezing. The freezing does respond to sensory tricks and cues, but the immediate effect of these sensory cues does not last consistently. It has a very inconsistent impact. So longer periods of cue training are required for these patients to help these cues. So visual, emotional, and cognitive triggers, especially distraction, they lower the threshold of occurring of freezing, and cueing strategies can be given by the physiotherapist to the patients, prescribing walkers, and emphasizing to the patients to use walker and how they can use walker in a more practical way is very important in the freezing of gait, because some patients it's natural that some patients do have a hesitancy to use a cane or a walker because they feel social embarrassment, and they also feel a kind of stigma that they are using a walker in the public places. So they were able to walk without any assistive devices before. So physiotherapists can emphasize on that and can train them to have the use of walker in at least those situations in which they have increased risk of falls or increased risk of freezing. The off freezing could be improved by levodopa. So, and you can sometimes add other medications to it, such as entacapone, which can increase the half-life of levodopa, or maybe razagiline can increase the half-life. So these things can probably help to improve the freezing in the off periods. These type of treatments can decrease the duration of the off periods as well as the frequency, and therefore the freezing episodes are decreased as well. The on period freezing is quite difficult to diagnose because it's much less common, and some patients may not have very robust on, and they may not be able to provide the good history of the on freezing. In the advanced stages of Parkinson's disease, the freezing could become very resistant to treat, to levodopa. The on-freezing is even more difficult to treat because you have to lower down the dosage of medication. Sometimes what happens, patients report that they are quite slow, but during the on periods, if they have freezing, so the physician tries to treat the slow periods and gives the higher dose of levodopa, which makes the on-freezing worse. And sometimes these patients could just be presenting with a history of falls, that they have started falling, and the falls are usually in that period, which is considered an on period, like about half an hour after the dose of levodopa up to a couple of hours. In that period, if they start falling more, so you should be quite careful to take the history of unfreezing, because that could be a possibility. And then instead of increasing the medications, you may have to lower the dosage of levodopa. In some reports, subthalamic stimulation has also been reported to improve the off-freezing, and in some patients, the benefit from levodopa is probably greater than subthalamic stimulation, and levodopa and subthalamic stimulation could have an additive effect if the patient has already subthalamic stimulation and they're on levodopa, so they are having off freezing. So you adjust the dosage of levodopa. It could help additively. The subthalamic stimulation is ineffective, usually ineffective for levodopa-resistant freezing, and most or any of the symptoms which are not responsive to levodopa. Usually subthalamic stimulation does not help them, and this applies to freezing as well. If the freezing is resistant to levodopa, subthalamic stimulation may not help these type of patients. There has been some interest in the past about the surgery involving pedunculopontine nucleus, the PPN. The stimulation of PPN was done in the past in some patients who had on and off periods, and some of the results initially were encouraging. This is a nucleus in the brainstem which has the reciprocal connections with basal ganglia, and it's part of the mesencephalic locomotor region. So this nucleus has the projections with the spinal cord, and it controls the muscle tone and locomotion, and therefore some of the reports did suggest that stimulation of PPN might help freezing of gait in these patients. There were some reports of progressive supranuclear palsy patients who would treated surgically stimulating PPN, but that enthusiasm seems to have become much less now. There was evidence for the role of PPN in modulating gait from the post-mortem studies, because there was a quite significant neuronal loss in PPN in the advanced Parkinson disease patients. There was also some evidence from the progressive supranuclear palsy, in whom the freezing of gait and partial instability starts from the beginning of the course of the disease, and there was neuronal degeneration in the postmortem studies in these patients. So surgery could have a role, as I said, but usually in those patients who have a good response to levodopa. But otherwise, if the levodopa is not helping the freezing of gait, the surgical treatment may not also help the freezing of gait in these patients.
Very good, Dr. Rana. Well, that takes care of part 1 of freezing. Stay tuned. We'll be back for part 2.